We'll go on to the next talk. Next speaker on the stage, please. I think Jacob, what is the new with vasopressor therapy? Dr. Jaicob Varghese is a senior consultant and head of the Department of Critical Care at Rajgiri Hospitals, Kochi, who is specialized in critical care, special interest in toxicology. Over to Jacob. Without wasting much time, we are running short of time. What is new with vasopressor therapy?
Thank you, chairpersons. I'm just waiting for the slide to get loaded here. Good evening, my dear friends. I hope you had a good lunch, and I'm standing between the lunch and a good sleep. So, till the next debate by my two friends, they will keep you awake. I need to keep you awake. Can I have my slide? Yeah, it's coming. We have been listening for the past half a day regarding sepsis management, circulatory failure, and vasopressors has been touched now and then. What is new with vasopressor therapy? I don't think anybody has got any confusion what is there. However, all of us by law and by experience or by practice or by reflex, when a septic shock patient comes to you, fluid is the first one. And you know that the hypotension is predominantly systemic vasodilatation, so you tend to start a vasopressor therapy. However, having said that, every deed you do comes with a lot of controversies. So, with regards to vasopressors in septic shock, which, when, and how much clarity is there, however, still some controversies and new things are coming. This is a slide which you must have seen from physiology days that to tell that where exactly the vasopressors act. The catecholamines predominantly act at the level of your B1 and B2 receptors. However, having compared with alpha and beta receptors, there are other modalities also which can help physiologically to improve your blood pressure, which includes the arginine vasopressin, where you have the vasopressin and a couple of analogs which has come into picture. We have the angiotensin 2 receptors here, where we have angiotensin 2 acts on the angiotensin 2 receptors, which also is subclassified, and there are some molecules which has come into the picture because of that. You know this mechanism of action, you know what is the dose, I'm not going to come into it. This particular thing what I mentioned here, compared telepressin, celipressin and angiotensin 2 are the molecules which has got some interesting data which we'll discuss in the coming for something which is new. The first question to be asked, when a patient comes in septic shock, which vasopressor should be considered? Surviving sepsis guidelines clearly put it across that after fluid resuscitation, start norepinephrine as the first agent. If the BP is still, MAP is not maintained, you consider the second agent, which is vasopressin as of now. Epinephrine also can be considered predominantly if there is a cardiac dysfunction. However, the evidences what is been shown, the VAST, the VANISH, the two trials which compared norepinephrine, vasopressin, even though it doesn't show any mortality benefit compared with these two. However, adding a vasopressin or vasopressin doses in septic shock seems to be having the MAP target has been achieved quite early, and the need for renal replacement therapy is slightly less when you take vasopressin on board. However, there's another post-hoc analysis of the VAST trial which compared norepinephrine and vasopressin. Vasopressin has been effective in less severe shock. And adding a vasopressin to norepinephrine, the target of MAP is achieved little bit earlier. So you need to consider adding vasopressin to norepinephrine when the shock is not reversed. And the intent is to raise the MAP and to decrease the norepinephrine dosage. Catecholamines is toxic by its own mechanism. So to reduce the dosage and intent to increase the MAP, we can use vasopressin. And of course, when you do that, the deleterious effect of adrenal load can be decreased. And more catecholamines, more complications, which includes tachyarrhythmia. This JAMA paper has shown in cardiac surgery patient in sepsis, adding vasopressin has reduced the incidence of atrial fibrillation, which has got a lot of implication in the ICU. Now, even vasopressin, as compared with catecholamines, the therapeutic window is narrow. It has also got toxic effect. That comes the next picture on the line. When you have the classical mechanism of BP, systemic vasoconstriction, there's another mechanism which I mentioned where the angiotensin 2, which combines with the AT1 receptors, and that is why the RAS, the renin-angiotensin system, also comes in play physiologically to help your BP better. So why can't we use that? That is this particular paper, which some of you knows that, which is called as the ethos trial, where angiotensin 2 is being used to treat high output shock. Norepinephrine, patient was on norepinephrine more than 0.2 mics per kg per minute. RCT divided into two groups, 300 patients, and they used angiotensin 2 as a second molecule, to maintain the mean arterial pressures. The primary endpoint, what they looked was that the MAP response at the end of 3 hours, which was found to be statistically significant in this particular ethos-T trial. Even going forward, the SOFA score at the 48 hours, because the BP has improved, SOFA score has come down, has scored some benefit. Even though the mortality doesn't have much of a difference between the group, which control group and the test group. However, one important thing is that the dose of norepinephrine, that means the norepinephrine equivalent dose, what has been used, was much, much lesser, which will ultimately end up in reducing the toxic effect of catecholamines. Now, there was a pre-specified analysis of ethos-3 trial, which was published in Annals of Intensive Care Medicine. In this particular group, the angiotensin 2 dose was used 5 nanograms per kg per minute doses. So they did the baseline assessment of angiotensin 2 levels. And the patient who required lesser dose of angiotensin 2 has got they found to have lower levels of angiotensin 2. So what does it mean to a clinician, or what does it mean in a research question is that, when you start off a second drug earlier in the course of the disease, that helps us to get the MAP better and also to reduce the effect of catecholamines, which ultimately can have some sort of a value when it comes to the ultimate result. So, and angiotensin 2, in another study which compared all the shocks, apart from septic shock, it has helped in increasing the blood pressure. Have it reached the guidelines? No. Still, we need more data to confirm what is the role of angiotensin D. However, in profound hypertension, where norepinephrine dose is skyrocketing, probably angiotensin 2 comes into picture. Now, what about the other molecule, which is terlipressin and celipressin? We are familiar with terlipressin in patients with the hepatorenal syndrome. We use as a molecule. With regards to septic shock, the trial which was published in ICM, Intensive Care Medicine 2018, did not show any benefit, mortality benefit, and it has got more adverse effect. Another problem with limit terlipressin is that its half-life is very long, which makes it difficult to use in a practice which is in septic shock. Hepatorenal syndrome, intermittent dosing, or a smaller infusion we can definitely use. But septic shock, probably the half-life is an issue. The other molecule called as the celipressin. Celipressin, compared to vasopressin and terlipressin, has got a selective V1A receptor agonist action. However, the Sepsis Act trial in JAMA, when you compared with that, there is no benefit seen with regards to ventilator-free days or vasopressor-free days, and the requirements and the vasopressor-free days was not at all different. So, celipressin is still an investigational molecule with regards to septic shock. Another important point, we all look into lactate in the ABG when a patient comes to you. The lactate helps us to know where are we standing, and of course, lactate clearance has been taken as a prognostic marker. Can lactate help in deciding on vasopressors? That is the next question asked. It can always, because especially when you consider second agent, if you're considering an epinephrine, adding an epinephrine which causes increased lactate again. So adding a non-catecholamine vasopressors to a current existing norepinephrine, the lactate levels can have some value. These two particular papers which considered when to add vasopressin with regards to lactate, in this particular paper in CCM, less than half of the patients receiving vasopressor experience a favorable hemodynamic experience when it added on to norepinephrine. However, in the patients where lactate was low with hypertension, the hemodynamic response was twice as compared to the other group. Similarly, the mortality, adding of vasopressin to first-line norepinephrine, if it is delayed, the odds of hospital death was increased if the lactate is going up 18% if it increases 1 per minute. That means the mortality of the patient with the second agent, vasopressin, is delayed. If the lactate is going up, it is going to be higher. And the hemodynamic response, what we get with the second agent, is much better when you have a second molecule in place when the lactate is higher. So when to use vasopressors? So if you ask me which agent to be used, I think the recommendation remains to be same. However, you need to consider angiotensin 2 as a second molecule or a third molecule if there is a profound hypertension. Second question is that when to use vasopressors? It is not the degree of hypertension, the duration is important. And the MAP target can be achieved with early initiation of norepinephrine. And also, the norepinephrine sometimes can have a synergetic effect with even to IV fluid. It could also, by increasing the venous resistance, it can increase the cardiac dependency. And similarly, when it comes to microcirculation, early use of norepinephrine can sometimes, this theoretical value, recruit microvessel and improve microcirculation. So when you have a norepinephrine on board, when the diastolic BP is increased, the coronary perfusion pressure curves can go up, which ultimately can end up in improving the left and right ventricular systolic function. And also, most important, Trujillo talks about deresuscitation. More fluid can be more harmful. Early norepinephrine can always prevent a harmful fluid overload state. So, practical point when to start is that you just need to start urgently. You can look at the diastolic arterial pressure as a surrogate. If it is low with tachycardia, less than 50, that's a target we can always consider. Decreased vascular tone is there, you need to initiate norepinephrine, even in the peripheral venous axis, which we are all practicing right now. We don't need a central line to start with, ultimately we can place that. So, when to use, earlier the better. Now, how much do we give norepinephrine? You know, the data comparing two MAP targets of 65 to 70, 80 to 85, it does not have a benefit because 65 to 65 is equally good, more MAPs doesn't require. However, there are three subset of patients where in the higher target of mean arterial pressure with respect to norepinephrine doses has been beneficial. One is patient with chronic hypertension. The patient with chronic hypertension, when the norepinephrine, when the MAP target has been increased, it has been found to be having a less incidence of renal replacement therapy, requiring RRT and renal failure. The other two groups which I would like to mention here is that if you have a high venous pressure with regards to CVP being high or with regards to IAP, almost many patients in the intensive care unit, by the time we give fluid, the abdominal compartments in all the intra-abdominal pressure can be elevated. So people with elevated IAP, that high venous pressures, this is a group which can end up in organ dysfunction, which includes renal failure. So targeting a high MAP can be beneficial with regards to less incidence of renal dysfunction in this kind of group of patients. Similarly, how do you work to choose that? If you want to increase the MAP or if you want to achieve the thing, you give a norepinephrine challenge and find out which the best perfusion pressure. It is not easy to find out from the microcirculation. Probably guidance can be in these particular groups, keep a higher thing. What about using a bedside technique like capillary refill time? You know, CRT has been used as a surrogate for fluid resuscitation in circulatory failure. Similarly, a lot of data is coming up by using CRT as a marker of seeing whether the microcirculation is intact. So the CRT assessment, CRT difference, if you can reduce the number to less than 4 seconds by increasing your MAP, by increasing norepinephrine requirement, probably can be used as a surrogate. However, in patients with profound shock, patients with skin mottling, this can always be an issue. Is there a maximal tolerated doses? Still, it is not elucidated. More than 1 mg per kg is a rescue therapy for whatever data we know that. And of course, the mortality is high. There can be a lot of complications which includes a digital gangrene. So the deleterious effect of norepinephrine is always to be kept in mind. It can be harmful. Catecholamines can be harmful. So the maximum tolerated dose is, even though it is not elucidated, more than 1 is basically a rescue therapy, and even much before that, you should consider adding a second agent or a third agent with regards to hemodynamic management in septic shock. That is why everything is D right now. We call what is called as the decatecholamization. In steroids is one agent, probably we have seen over the years that data showed that steroid use, even though mortality benefit may not be there, shock reversal has been achieved with this. So similarly, by using a second vasopressors, we can always decrease the incidence of catecholamine toxicity, and that can help in the ultimate outcome. Similarly, when you have a strategy of early norepinephrine administration, this particular data compared that early norepinephrine compared with the delayed. So if you add norepinephrine early in the course of septic shock, it has been shown in this research in decrease in the total dose of norepinephrine over the 24 hours time. And if you want to use higher doses, maybe you can restrict to short-term use so that your target is achieved and you use other modality and decatecholaminize these patients for an ultimate outcome. Now, there's another paper which I've discussed is that is vasopressin, when to start the vasopressin. And the vasopressin initiation is always a concern. To start vasopressin, you need to consider what is called as the norepinephrine kinetics. This is the two group of patients where norepinephrine kinetics has been in two different ways. This group is a stable group. You start norepinephrine, the BP reaches here. This is the target, you start vasopressin. However, you may not require that because the profile goes like this. This is a group, even though it behaves like the previous one, there is an area where the norepinephrine dosage is going up, requirement is going up, and this is a time group where we need to consider giving vasopressin at the earliest. So norepinephrine kinetics, the exponential rise of norepinephrine requirement is one point you can definitely consider giving vasopressin. Similar to broad-spectrum antibiotics, we have what is called as a broad-spectrum vasopressors. The concept of broad-spectrum vasopressors is something which has come up in the Ethos 2 trial when they compared the data. The people who achieved the MAP at 3 hours, the probable survival was very, very better if the MAP is achieved in 3 hours. So similarly, and the Ethos trial combined norepinephrine with angiotensin 2. So when you talk about this thing, broad-spectrum antibiotics, similar to that, in septic shock, consider giving multiple levels of improvement in physiological mechanism by adding multiple mechanism so that the benefit can be good and can reduce the toxic effect of catecholamine. So start vasopressors with different mode of action simultaneously. You can always consider assessing the vasopressor sensitivity by sequentially removing that. Which one is beneficial, which target you want to keep. Future, you may get vasopressor sensitivity panel. So to conclude, my dear friends, start early, earlier is better. And now we are moving towards what is called as a balanced vasopressor approach. Early multimodal vasopressor therapy strategy may be more physiological than considering hiking up one, getting into toxic doses. And we now looking forward to have a closed loop systems where you have the MAP increment, which is culminating into what is there in the microcirculation. Combining both, the benefit is good. That is what we need to achieve. Hopefully, future will have more results on that. Thank you so much for your patient hearing.